Wonderful. Well, thank you everyone for joining tonight. Good evening. Welcome to our VCSQI Spring Quarterly Meeting. First, I want to start out and address the ongoing COVID-19 panic. And in light of everything that's going on in the world right now, I just sincerely hope everyone is safe. You're keeping in good health, both physically and emotionally. I know this is a tough time, but we'll get through this. The last few weeks demonstrate the importance for all of us to come together as a community for the common good, now especially more than ever. Our agenda tonight focuses on innovative ways to improve heart patients' lives, from enhanced recovery to the latest analyses from the VCSQI database. This is really our first fully online quarterly event, which is taking place via Zoom. So to ensure a smooth meeting, we have a number of tips that will help out. The first slide here shows the basic functionality with regards to the chat feature, the ability to mute your line. If you have any background noise, please mute your line. If we detect that there's a signal coming from your end, please don't be offended if we end up muting you ourselves, and you can always toggle the unmute feature and take yourself back off whenever the disturbance is clear. There are also a number of features down at the bottom of your screen. They're shown here on the screenshot. You can access those via the participants window. From there, there's a feature to raise your hand. If you'd like for the presenter to pause and ask a question, the presenter will get a notification saying a participant has raised their hand. You can also use the chat room to ask questions. You can access chat by either clicking on a name, or that's one of the options on that bottom window as well. We'll also have a number of polling questions later on in the evening, so please look out for those. And in the background, Ms. Sherri White, our wonderful colleague and VCSQI's Quality Improvement Advisor, will be helping to facilitate discussion and just making sure that everything runs smoothly. This is another look at the chat window, and I'll just send a brief message. You should be able to see that a little notification came through, and if you click on that, you'll be able to see the chat and respond there. So that's kind of the housekeeping items. And again, this is a collaborative meeting, so feel free to stop us if you have questions. We'll also have a number of segments that are planned for discussion and QA. We're also offering CME credits tonight, even though we're online. We got a CME office to approve our meeting, so I'll pause here if you want to take a screenshot. Alternatively, feel free to email us afterwards. We'll send out this information as well. But this is the number that you have to text with this code. And afterwards, you'll get a survey which will allow you to access those CME credits through the VCU online system. So I'll just pause here real quick. Does everybody have that info? And again, we'll send these out later too. All right. So before we launch into our full agenda, I wanted to again, touch base on COVID-19. I'm pleased to introduce our first speaker of the night, Dr. Robert Shor, our cardiologist extraordinaire who practices at both the Inova facilities as well as Reston Hospital Center. Dr. Shor is VCSQI's newly elected chairman, and he'll provide updates from the board. But first, I feel it's exceptionally important to cover COVID from a personal level. Dr. Shor, I want to pass you the ball here and just ask you, what are your recommendations as a clinician, not just for the healthcare community, but for really the entire American public, that can help us to flatten the curve and possibly save thousands, if not millions of lives of both patients and providers? Dr. Shor, thank you.
Thank you very much. The COVID-19 has been referred to as a tsunami, and we're trying to make it a quieter flood. I was on a health affairs committee call last night with the American College of Cardiology, and on the call was a practicing cardiologist in northern New Jersey outside of New York, and they are really being overwhelmed. The most important thing to allow us to be able to take care of these patients, I think at this point, is identification, isolation, and really past that, because that's really problematic at this point, is social distancing and washing your hands to limit and slow the spread so it doesn't overwhelm the systems. Within the systems, where there are a lot of things that folks are doing as far as trying to save PPE, personal protective equipment, minimizing contact with the patients, shared physical exams, and a whole host of items that are evolving, video visits in the hospital, and a whole variety of things. It's disheartening to see how rapidly this is spreading and overwhelming our ability to care. So take care of yourselves and take care of the patients. If I might, at this point, before I give the update on the board meeting, because the first part of the board meeting was on COVID-19 also. Eddie's done a great job going over the rules of the road as far as raising your hand or writing a question or a comment. It's easy to do, and we are surveying that. I also wanted to say you have the agenda in front of you, and I wanted to thank all of you as participants and for all of the speakers on tonight's webinar meeting. And at the end, Eddie and Sherri are going to, in the future, send out just a query to see what you thought of the meeting, what went well, what didn't, and make sure that this is fruitful. We, at this point, really don't know what it's going to be like in June for our next meeting, and whether or not we're going to have a repeat video meeting, or whether or not we'll be able to meet in person. And so anything we can do to optimize this experience, we really want to know. COVID-19 is been on everyone's mind, and we asked ourselves at the board what we could do as a board to help our Commonwealth community of institutions and providers. There were a variety of items, but amongst them were providing the common resources that are available from CDC, STS, ELSO, ACC, and others. We also understand that this is an incredibly stressful time, and we'll provide some information on self-care, because caring for ourselves and our providers is going to be critically important to allow us to be able to go through what is likely going to be a very challenging time. We have not really seen the influx quite in Virginia yet, but it is coming. Included in that are some things from the VA system on how to manage self-care and infectious disease as well. We talked about guidance and not guidelines. This is a moving target, and new territory for everyone, and one situation is very, very different than another. So we're going to try to provide some guidance, not guidelines. And we're also going to post a video on proper use of personal protective equipment, how to don it and how to duff it. Recognizing that this, at the present time, is the best way we can avoid getting the disease. So we're going to make that available as well. The next item on the board agenda, we talked about the financials, and we are in a good position at this point, and we are obviously quite solvent and doing well. The second thing we did want to mention is we discussed and approved that the scholarship or reimbursement to the chair of the data managers for participation in the STS and NCDR registries. The exact details will be determined, but we value all of the data managers, and we thought this was an important thing to be able to express our gratitude and the importance of participation and being up to date. So I wanted to share that with you as well. The exact method we do it, we'll have to look and see what is the best way to do it from a personal financial standpoint and for the system. The next item was that we had 2 board seats available on the board, and the intent is to have 4 administrators, 4 cardiothoracic surgeons, and 4 cardiologists. So we are extraordinarily pleased that Dr. David Wyatt, a cardiothoracic surgeon from Carillion, who has been in practice for 25 years, has been in Carillion for 11 years, did some training in UVA, and so is very, very familiar with both VCSQI as well as the Commonwealth. So a hearty thank you. We have made offered a board seat to a cardiologist and tentative approval, but we'll update at our next meeting to meet those demands. The last is just to update that, as you all have heard from Dr. Lebdell on numerous occasions representing Atrium Health, there's a patient safety organization that we've been asked to engage with and participate with, and we will likely do that. We are in process of looking at the additional details and how we might move forward with that. So we're very excited about that opportunity as well. I did want to say that something that's been very much on folks' minds is getting some of the new data sources. And we have information from Virginia Health Information, VHI, and the all payer claims database for over 24,000 patients and 10 million claims. And Eddie's going to present some of that data. So that was a missing piece, particularly from the outpatient portion of the cardiovascular world that we are beginning to look at and really will fulfill many of the needs that we have. We're continuing to work on the ACC STS TVT registry and combining, working with the STEMI registries with VHAC, both ACC CP, chest pain MI, as well as the AHA's Get With The Guidelines CAD, in an effort to be able to provide more comprehensive information regarding performance in the Commonwealth. And those will be incredibly important for us moving forward, both the STS ACC TVT registry and working with VHAC. We are waiting on information from ARMUS, and really that's where we're hoping to move forward and have an update on some final information and to be able to present at the next meeting. Eddie or any of the board members, that was a rapid fire overview of the information. Any updates or addenda that you want to add to that? Alan, anyone else? Okay, I don't hear any other voices. So at this point, Eddie, I guess we can move it forward with the continuation of the meeting.
Very good. Well, our next item on our agenda, and again, feel free to jump in with any comments, questions as we move along here, is an update on the VCSQI strategic planning exercise. And for that, I will pass the ball over to Ms. Sherri White, who will give an update on where we are in terms of our planning and VCSQI's objectives for 2020.
Good evening, everyone, and thank you so much for spending your evening with us via your computer and from the comfort of your home, I'm hoping. But just to recap, we wanted to share with you our usual slide of what our strategic plan, what we all started or created together, our mission, which we enhanced, which is to transform cardiovascular care to improve patient experience and value, and of course, our vision and our core values. Now, before we dive in deeper as it relates to what we're going to do different to enhance our strategic plan, we need to take a moment to look back and celebrate what we've done with our strategic plan by looking back at what we've done from 2019. So, of course, you brought in a very valuable, beautiful quality improvement advisor. I just had to throw that in there. Thank you for having me. And since I've been here, you know, we kicked off the Quality Improvement Initiative. We started increasing our communication efforts. We've been sending out monthly newsletters. We started several task forces that included our data review committee or task force, working with Gyula. We've started our enhanced recovery task force that combines cardiology and surgery. And we did various other different type of strategies to help push us towards the next level of what VCSQI means for the state and that possibly the world. So still looking back, actually 1 year ago, probably to the day, we attended our quarterly meeting in person at Boar's Head, and we participated in a robust exercise in group forum or group settings where we strategized on how could we better improve the strategy and the mission of VCSQI. So together, collectively, we decided that we had 4 pretty much buckets that we should focus on for 2019, which included, you know, creating a larger footprint across the state and the nation, increasing collaboration, harmonizing cardiology and surgery, and of course, education. Now, as it relates to what we've done going forward, here is a snapshot of a grid of the milestones or tasks that we had associated with the different categories or buckets that we've created. And also in this specific slide, you will see a new category that was added specifically, which is integrating cardiology into VCSQI. We wanted to make sure that cardiology data integration was pretty much up to the same level, up to the same part or level as our surgery group. So we created a couple of different projects to help get us to that level. And this slide kind of shows you a snapshot of where we've come. The green indicates projects that we have completed. Yellow is projects that we are currently have in progress, and red are projects that we have not started yet, typically because it takes a little bit more time to do. And we hope to have those kicked off this year. So in terms of what we have planned for 2020, so in addition to those numerous surveys that we send out to each of you, we send out a numerous amount of surveys to our board members. So Eddie and I compiled a couple of different documents preparing or summarizing what all we've done in 2019 with efforts to build on to that morale and that momentum to help enhance our strategic plan for 2020. So we have 5 proposed priorities, and one would be engagement. And under that category, or what that goal means, is to create opportunities for active members to thrive and dormant members to emerge. Under that is subcategories, which is to provide evidence-based reviews, identify strategies to develop or highlight best practices. Also under this category is education and enhance the skills and knowledge of our members. Our second category is to diversify our membership, expand our collaborative opportunities to improve heart health of all of our patients. Our third is to expand our database. And of course, we have some great announcements to include or introduce that to you later on in our segment. We're going to improve on our performance reports. Fourth is increase our strategic growth. You know, continue to build on opportunities within VCSQI. And of course, last but not least, recruit. Expand programs that extend the reach of VCSQI. So after this fabulous meeting, I'm going to send you all out 2 surveys. The first survey would be the VCSQI 2020 priorities. It will be those 5 surveys. Just give me your input. Do you feel those 5 surveys are the 5 categories? Do you feel those 5 categories are the categories we should focus on? If so, what are some different milestones that we can add under those specific categories? And also, what are those priorities? So let us know from your standpoint, your perspective, what is important to you? We want to know. The second survey we're going to send out to you is also this quarterly meeting feedback. We want to know how this experience is for you. Another reason why we're doing this virtual meeting, in addition to the crisis, is also to be able to expand our reach. So let us know how this feels for you. So expect 2 surveys from me. So I am done with my portion, and to introduce our next speaker, I am going to pass it over to Chris from Winchester, who is also an esteemed board member. And Chris, your turn.
Thank you, Sherri. Can you hear me?
Yes. Yes.
Okay, cool. It is my great pleasure to be able to introduce Susan Warriner. Susan Warriner has been a nurse practitioner with Valley Health Cardiothoracic Surgeons since 2012, where she provides pre- and post-operative care for adults undergoing cardiac surgery. Her initial career path was in music after being graduated from Mary Washington College in 1988 with a Bachelor of Arts degree in classical piano. While awaiting graduation, she took a night shift job at Warren Memorial Hospital in 1987 as the on-the-job trained ICU cardiac monitor technician. And I think we can all relate to our early days at night shift. After discovering a keen personal interest in anatomy, physiology, and critical care medicine, she changed pathways and was graduated from Shenandoah University in 1994 with an associate degree in nursing, and was hired directly into the intensive care unit. From there, she obtained a bachelor's degree in nursing at Old Dominion University in 1999, a master's in nursing administration from George Mason University in 2005, an adult postmaster's nurse practitioner certificate from Ball State University in 2012. This May, she will graduate with her Doctor of Nursing Practice from the University of Alabama. Today, Susan is going to present results of her DNP joint initiative with Winchester Medical Center, entitled Implementation and Evaluation of the Use of an Application-Based Patient Education and Engagement Product in an Adult Cardiac Surgery Population. Susan, we are thrilled to hear your presentation. Thank you for coming.
Thanks, Chris, for that very nice introduction. I'm not going to be quite as formal as you were. So let me see if I have the mouse. I do. Okay, so my name's Susan Warriner, and the majority of my job is not just the physical assessment and making sure everybody is, doing well from a recovery standpoint, but I think my best talent is educating my people, my patients, either before surgery or after surgery. So in late 2018, our service line was looking at those expert recommendations that had recently been released, and I saw in those that there was one that addressed patient education, and so that really said something to me that I wanted to look more into. A couple coincidences that led to this. So at the same time, the service line leadership, who was, at these committee meetings, said that there was a mobile technology patient education product being used in another service line, and would we like to have access to it to try it for our patients? And since I like education, I volunteered to take over the project to look at this product, see if I could modify it from orthopedic surgery actually to cardiac surgery, and then implement it for our population and then do a program evaluation of it. And because it was the time I needed to pick my doctorate program, I decided that I would make something out of this into a research study. So I'm really going to go over this, some of the dry parts very briefly, because you can read it in the slides when it comes, but I'll spend much more time over the meat of it. So, all right. We all know that patients do better if they're educated, and you have to match up the education mode to the way that the patient best understands, and that differs from patients to patients. And education needs to begin preoperatively, and it should not stop when the patient leaves the door, when they're discharged home. It needs to start preoperatively and continue through the full recovery period. At our site, we did not have a consistent process where every patient got the same amount of education and received the benefit of having a complete education. So we don't have a nurse educator. We don't have a nurse navigator for cardiac surgery. So it depends on the provider, the APCs, nursing staff, and when you get a lot of people involved with providing bits and pieces of education, it's pretty hard for the patient to get the complete package that they need. So this is what I had just said, that patients interface with a lot of different people. As expected, when you have different education modes, you get a wide variety of variation in the style and the depth and the breadth of the content. And so since we had this product, we thought this may be a solution for our patients. The product was pretty easily modifiable. I rewrote all the care plans for cardiac surgery, for Cabbage, for valve intervention, and for elective aneurysm repair. And the other good thing was it was going to be free. So I had already looked at some other similar products that maybe offered a little better options, but when something is offered to you for free, we thought we would go ahead and trial it, see if there was any value in it, and then if the time ever came that we could branch out into a more robust product, that we would have some data to say, yes, this is worthy, this is beneficial, and something that we should look further into. So I turned this into a study, and it was really to, implement a product, evaluate it for its, usability, and how did it compare to other products, and what did our patients think about it? Was this just going to be a pilot run and stop, or was it going to be a pilot run and then become permanent? And it was interesting, when I first started this project in 2018, the recommendation at the very end, it says, after it says patient reported outcomes, it used to say could be beneficial, might be. And now it has changed to say that this methodology are recommended. So they've actually changed, kind of put a little more oomph behind this recommendation. So I'm not going to go over the timeline too much, but just wanted everyone to know, which you do, that it started with Kellett and just had a stepwise progression from non-cardiac surgery to cardiac surgery, and then drilled down to the pieces of education that helps a cardiac surgery patient have better outcomes, and that was the education component. And then some of the very last research was that mobile technology has merit, and mobile technology has merit in the older population, which is the majority of who we serve. So it was just a retrospective investigational study, and what we did was every patient who was going to have elective cardiac surgery who met the criteria, they had to be 18 or older, and it was planned Cabbage, valve intervention, or thoracic aneurysm repair. Our goal was to get the email from all of these patients and have it documented within the EMR prior to the patient being scheduled for surgery. Once the patient was scheduled for surgery, this vendor that we used would send out an invitation. The patient would either respond to it or not, and then they would engage in this product from the date that they were scheduled from surgery all the way out to 30 to 35 days afterwards. So the sample pool, it was convenient sampling, and they were all consecutively enrolled patients for the first 6 months after the product go live. So just the method, I took all of those patients from the vendor report that said they used this product, and I randomly selected 50 out of these patients. And I was going to call all 50 patients and perform a telephone survey. And that was going very well until when I started the survey process, I started finding patients that were duplicated, and that created a problem, and I'll talk briefly about that later. This is probably hard to see, and this is just the process of this product for each patient, how this product is implemented, and all the pathways where we went wrong, and prohibited as many patients as could have been could have benefited from this. And by trial and error, we've learned from some of the things we did, and I'll speak to that. All right, so the demographics of the patients that I surveyed, it was a 2-to-1 male to female ratio. The age ranges for all of them are there, and the mean years are there as well. And the mean difference between male and female was about 10 years. So this vendor-generated report that I was relying on was erroneous. The problem was the vendor report goes off of the vendor-generated patient ID number, not the medical record number. So they reported that there were 119 patients who they sent an email, enrollment email to, and that 70 had accepted it, and 47, let's see, go back here, 47 had not. And once I did my sampling, and out of the 50 patients, actually the number of patients who enrolled was 60, and the number who did not enroll was 40, and that gave us a pool of 100 people who were actually sent an invitation after every error was corrected. So the reason for duplication, which is a problem if you're going to just rely on the report, was the enrollment process. The decision is made for surgery. The patient has a valid email already documented prior to being scheduled for surgery. The enrollment invitation is auto-generated. The patient does or does not accept enrollment. Here's the problem. Surgery date gets postponed. Every time surgery date gets postponed, patient drops out of the product roster. And when the patient is rescheduled for surgery, they appear like they are a brand new patient. So if a patient is rescheduled one time, they show up as 2 times. So the vendor report makes it look like there are more patients than actually did. So this, after the correction, so these are interesting statistics and why we want to do better. So only 60% of the patients who had of all eligible patients, 100 out of 168, actually had an email on file. And it's our staff's responsibility to gather these emails, and we didn't have a consistent process or a strong enough process where patients didn't get missed. 60% of the patients who were sent an invitation, they did enroll. And overall, though, only about a third of the patients who really, who benefited from it, reversed that. 2/3 of the patients did not, they did not enroll, they didn't get the benefit of this product. So we have to work on that. So these are just briefly some of the survey questions. Just the high points I want to hit on is just in general, does interactive telehealth technology appeal to you? And out of our 31 somewhat older, middle-aged, and elderly patients, 28 out of 31 said yes. I should say out of my 50 patient pool, there were several patients who could not use the product, said they never enrolled even though the vendor report said that they did. They said they had vision problems, they became too sick, their surgeries were canceled. So once those 50 patients that I thought I would be able to perform a telephone survey, once that data was cleansed, there were truly only 31 patients who would have been appropriate to receive the survey. And if you remember some of the mean ages, 90% of those people said, yes, it appeals to me, I liked it, it was helpful, and yes, it has value. Couple improvements that they wanted to make is, unfortunately, because we wanted to send an email every day to keep the patient engaged, you know, the phases of recovery doesn't change every day. So there were days when patients received some redundant information, but we didn't want to lose them from making a daily contact with the product. And I went over this. We were surprised. I mean, of course, we knew that it would be informative, but a lot of patients said, you know, it gave me a feeling that you cared. You cared enough to keep in touch, and it made me feel valued as a patient. Things they didn't like was really the repetition of content, and some of the other answers were not significant as far as numbers. It says, did using the product enhance or positively contribute to your overall surgical experience? We just wanted to gather their opinion about this. And 29 out of 31 said, yes, it did make a difference. I think it benefited my whole surgery experience. So, you know, the findings were overwhelmingly positive for this. And nobody said no, and only 2 people said that, you know, they were kind of indifferent. They could either take it or leave it. So the last question I asked is, rate the product. You know, 1 is the best and 10 is the worst. And when you get over to what the median was for male and female and total, you know, the results are pretty favorable, that the product has some value. It may have some issues that need to be worked out, but, you know, it has some value. And I guess one of the biases is that this is a self-selection of patients who decided they wanted to use the product. I don't know how much that really matters for these findings. I still think that, you know, there is value even though there was self-selection in it. So overall, you know, it was well received by the participants. They thought it was a valuable addition to their experience. We have some bugs to work out in this from a systems process that more patients could have participated if we were able to identify these barriers earlier. The positive aspects were the thorough information, feeling cared about as a person, education enhanced the recovery, easy to use, and the big thing is they could get the information at their convenience when they wanted to. If they wanted to, you know, get some education at 12 o'clock at night, you know, they can do that. The only issue is, you know, they can't talk and interact back and forth to ask questions, but the education that was in the product was pretty robust, and I would think most of the patients could have found an answer to their question no matter what time they were looking at the product. You know, we could have asked a surrogate user for patients who didn't have an email on file. Those who said they didn't want to give an email, because we did have that documented that some patients declined giving their email. Maybe if we had explained the reason behind why we wanted the email, they would have been more inclined to participate. One of the other products that I looked at had the ability to do all this through text messaging, and the product we used did not. So I think if we had the ability to do text messaging, our participation would have been higher. Too many opportunities for disruption. You can look through that colored chart that shows you the process from start to finish. There were some product and vendor or site and vendor IT interface problems. I would like their reports to be more accurate if some way they could identify patients by medical record numbers and eliminate duplications. Reduce the redundant content. And this is just the overview. You know, education is integral to the outcomes of our patients and their satisfaction. You know, it can improve their experience, their satisfaction, promotes self-care behaviors, impacts patient outcomes and population health overall. You don't have to worry about older people not being able to navigate technology, because I did not find that in the results. And overall, literature supports that mobile technology is useful adjunct in an aging population. Kind of some of the same things, promotes self-care behaviors, increases patient engagement. It can augment routine. So for the care that the education the patient gets preoperatively or intraoperatively or postoperatively, you know, this augments that, and I think gives better overall outcomes for the patients. And some of the literature had said that, you know, it reduces negative outcomes over the first 30 days. And I didn't include that as part of this study, but it would be interesting to go back and do a retrospective chart review and see if this holds up as a valid statement. And then these are just the references. So my question is, do any of you all use any mobile technology-based product for patient education or enhancement? Do any of you have those?
We'll open up.
Okay. So we're open for questions?
Yes.
So what I wanted to know is, do any of you as attendees use a product like this at your facility? Or are you thinking about using a product like this?
And if anyone has a question, feel free to use the raise your hand feature or unmute your phone to ask the question. We have Dr. Spear.
Yes,
Please go ahead.
yes, thank you very much for this. It's you've raised numerous points, and I think in this day and age, it really helps us to see what we can do next as we go forward, with or without sort of the distancing. But one of the things we were up against is just sort of the technology limitations and obstacles, particularly in the older group. So, or did you find some of your limitations were just the inability for the participants to know how to respond or have a facility to respond? How do we dumb this down, for lack of a more professional way, that our older patients particularly can really be engaged and not be intimidated by the whole technique of how this is formatted?
Sure. Well, like I said, I think there were only a couple patients who, once they looked at the product and tried to use it, had difficulty. And most of the difficulties was vision related. They couldn't see it. They really didn't tell me they had a problem navigating through the product, but it was just they had vision problems, or one of them had a cognitive issue because he had had a stroke. So what I did find was several of the patients used their spouse as a surrogate. So the spouse would read the questions to their other spouse and you know, use the product as a surrogate. And so when I did the survey, I spoke with the surrogates because they were, you know, they delivered the information secondhand to the patient. I started out the survey by speaking with the patient, but when they said, you know, I couldn't see it or I couldn't figure it out, I let my wife do it or I let my husband do it. So you can enroll any surrogate. It can be a spouse, it can be a friend, it can be a son or a daughter. So there is flexibility for those who may not be able to navigate it. They could have someone assist them.
Thank you very much.
Do we have any additional questions?
What product were you using?
Sure. So I don't guess it's a problem to disclose, but I started out because we have the Get Well network here at the hospital. When I originally started with Health Loop, and then Health Loop was acquired by Get Well Network, and now the product is called Get Well Loop. Get Well Health Loop. Yeah, Get Well Loop. And so that's who we're using. And that's only because they were already available in the hospital and there were unused subscriptions, and we got to pilot this for free. Now, if money was no object whatsoever, the other product I like much better was Seamless MD. But of course, there's expense. I like them because they seemed a little more robust. They had better standard care plans. They had the ability to network with all their other users and share best practices, and get all kinds of statistics from other programs that are using it. And they had text messaging and you know, and by phone. And there was only one option with this, which was by email. So the patient would get their email and there'd be a link embedded in the email, and you'd click the link, and then that would take you to their platform. So you had to have email. You couldn't use it if you didn't. So I'm sure everyone's heard of Seamless MD. I would have picked that if I could have. But if we ever have the opportunity to upgrade based on these findings, you know, I think you could make an argument for a better product, which equals a more expensive product. All right, well, thank you so much for letting me present. I know I speak fast because I wanted to stay within my 15-minute window. Thank you.
Thank you, Susan.
Thank you so much, Susan. So our next presentation continues our focus on enhancing recovery for heart patients. It's my pleasure to introduce Dr. Rawn Salenger, who is a cardiac surgeon at the University of Maryland, St. Joseph Medical Center. Dr. Salenger is a member of the ERAS Cardiac Society executive board, as well as the editor of the ERAS Cardiac Newsletter. He's also the immediate past chairman of the Maryland Cardiac Surgery Quality Initiative, the MCSQI. And for tonight, he's devoted hours and hours to preparing for our meeting. And even in this time when providers are stretched exceptionally thin, he's been just by our side and helping out in whatever way he can. And really, in my personal experience, his dedication as a leader and his passion for innovation are really unmatched. So with that, it's my true pleasure to introduce Dr. Rawn Salenger. Dr. Salenger, thank you for being here tonight.
Thank you, Eddie. That was a very nice introduction. I would like to point out that I'm still the chair of the MCSQI until May 7th.
Sorry about that.
I'm hanging on, Eddie. But thank you, everyone in VCSQI, for inviting me to speak to your group. It's unfortunate that it has to be virtual. I was looking forward to meeting everyone. And I think we have a couple other people from MCSQI, Diane Alejo and Terry Haber, I think, are tuned in. So thank you for tuning in. And I think Kevin Lobdell may be on the call, who's also just superior knowledge in enhanced recovery, so can contribute to the conversation vastly. But as Eddie said, I'm going to talk about enhanced recovery after surgery for cardiac surgery. Do I have control of the screen, Eddie?
Yeah, you should. I just have to click and it should advance.
All right. This is my first virtual talk, so bear with me. And also, especially, these are my disclosures, especially because it's virtual. Please feel free to interrupt with any questions, and we can have a discussion in the middle of the talk as well as at the end if something piques your interest. The things I'd like to talk about is why do ERAS in the first place? Why invest your time and energy? And it seems like there's a mixed group here. Some people already believe in ERAS, and some people may still be skeptical. So we'll touch a little bit on why we thought it was important at the University of Maryland. I'll talk a little bit about the components of our ERAS program at University of Maryland, which is a system-wide program. We have 3 cardiac surgery programs in our system. I'll talk a little bit about implementation, although that could obviously be its own talk, and then touch on ERAS successes that have looking at some data. We want to try to make this a little bit interactive, so we were going to pepper some questions through the talk, and just to get us started off, we thought we'd ask the question, how many people tuned in currently have a cardiac ERAS program at their hospital? Eddie, do I end the polling, or
No,
it looks like I'm in control? Or you'll do it, Sherri?
Yeah, I'll do
Okay.
it. I think we're good now. Okay.
Okay,
All right.
great. And everyone can see these results?
Yes.
Yes.
Great. So it looks like the majority of people are actually either already have an ERAS program or are in the stages of planning an ERAS program. So I think that's excellent. Oops. And how do we get rid of this? Do I just close it off? Okay. So a little bit about enhanced recovery. Most people on the call already know this, but it's evidence-based care that's meant to minimize the physiologic and psychologic stress of surgery to optimize recovery. And one very important thing is it's not just a written protocol, but truly a program and a culture change that needs to occur regarding your whole perioperative care, from the time the patient's identified as needing cardiac surgery to the time that they're home and back to their lifestyle. A lot of people that I've spoken to, particularly surgeons that are skeptical about enhanced recovery, usually it's because they just think it's not a big deal, or they believe that it's just, one surgeon in Maryland told me, it's just good post-op care. And actually I agree with both of those comments. And the concept of enhanced recovery is based on the concept of the aggregation of marginal gains, which means there's no one thing in ERAS that is a big deal. It's all small stuff. And it's the concept that if you try to do everything better, look at every single aspect of the way we take care of our patients, how we prepare them from surgery, how we get them into the OR, what we do in the OR, what we do post-op in the hospital, and what we do at home. If you try to make improvements in every aspect of what you're doing, that those small improvements will add up to something significant. And this concept of aggregation of marginal gains is not new. This is really an athletic concept that was first really made famous by the British cycling team of 2008, which they were obsessive about improving anything in their behavior that could make them perform better for the Olympics. They actually took hand washing lessons from surgeons. They changed everything in the way they stored their bikes so that no dirt would get on them. They brought their own mattresses to the Olympics so they could sleep better. They changed their entire diets, and they ended up winning 8 gold medals in the Beijing Olympics. So ERAS also is not new. As alluded to earlier, it was started by Kellett in the 90s, and in 2017, I think it spread in the early 2000s from colorectal surgery to other disciplines in surgery, but was largely ignored by cardiac and mostly by thoracic surgery as well. But I think this review in JAMA Surgery in 2017 by Ole Lundqvist, which basically looked at the colorectal hospitals in Europe that had colorectal ERAS programs versus hospitals that had colorectal surgery but no ERAS, and found a 30 to 50% improvement in cost and readmissions, decrease in length of stay, and decreased complications. I think that really got the attention of cardiac surgery, and people started to look at the possibilities of applying this to cardiac. And there was a slew of articles published following this article in how either trials or ways that enhanced recovery could be applied to cardiac surgery. And this really culminated in last May, the ERAS Cardiac Society And I believe Kevin's an author on this article, which became the #1 downloaded article from JAMA Surgery in 2019, which were the guidelines from the ERAS Cardiac Society regarding applying enhanced recovery to cardiac surgery. I think it's a valid question to ask, why should we do enhanced recovery in cardiac surgery? I do think that it's different than really every other subspecialty in surgery. I think we've been paying attention to quality improvement far longer than most of the other subspecialties, probably all of them. And obviously, if you had a colorectal program in the 90s that wasn't doing any quality improvement, had no standard work, and you implemented ERAS, you'd see a humongous gain in your outcomes because there's all the low-hanging fruit that you could pick. In cardiac surgery, it's quite different. You got in Virginia, you know that better than anyone. I mean, we modeled our quality collaborative on yours. You guys have been publishing on quality and cost reduction for years. You really have some giants in the field. So there's a lot of low-hanging fruit is gone. But the reasons, at least at Maryland, why we were intrigued by the possibilities of enhanced recovery are several. And the #1 reason was the experience that we're providing to the patients. And this was just an example of, this is an editorial from the New York Times that someone showed to me. This is a couple of years old, that talks about the concept that even when patients survive and get home and we think it's a victory and the patient looks fine to us, and on our outcome, dashboard, the patient's a complete win, these patients may not be back to being the people that they were before their experience, whether it be a big surgery or just a stay in the ICU. A lot of patients feel abandoned by their care team. They have nightmares, or they hear phantom alarms, and it's kind of a post-traumatic experience for these patients. And this made us at University of Maryland want to try to make the whole cardiac surgery journey smoother and as minimally traumatic as we could. Another reason has to do with getting the most out of the surgical benefit that we can get. And there's actually a whole large body of literature on medical therapy after Cabbage in particular. And this is a great study. There was even a simpler study than this done in Canada, where they took one of the most basic guidelines, which is dual antiplatelet therapy after acute coronary syndrome. And they asked Canadian surgeons, when you operate on a patient who and you do a Cabbage on a patient who presented with acute coronary syndrome, you discharge them on dual antiplatelet therapy. And 40% of surgeons said yes. And this was a study done, I think, in 2017. It wasn't that long ago. And so 60% of those ACS patients weren't even being discharged on dual antiplatelet therapy. This trial took it a step further and looked at optimal medical therapy after Cabbage in current REVAS trials. So looking at the biggest trials recently, comparing PCI to Cabbage, so Syntax, Freedom, Pre-Combat, BEST, and Excel. And they looked at compliance in the surgical arm with best medical therapy after Cabbage, which was only antiplatelet, beta blocker, and statin, nothing fancy. And they found that compliance was less than 60%, even in the setting of prospective trial. And this was the significance of their findings. On the x-axis, there's the difference in compliance between the surgical arm and the PCI arm. So as this number gets bigger, the surgical patients are less compliant with optimal medical therapy. And this is the risk difference between surgery, the primary outcomes for surgery or PCI, which basically means the benefit of having Cabbage over PCI. So the higher on the y-axis, the bigger the benefit. And you see, as the surgical arm becomes less compliant, the benefit from surgery is more difficult to demonstrate. So I think it makes a big difference if we're doing every little thing right before and after surgery. This is just a slide from one of our quality calls at VCSQI. This is just Maryland data. And in Virginia, you've published much on this. This gray line is the average cost of a cabbage at each center in Maryland. These are 9 of our 10 centers across the bottom. And these bars represent the total of the 5 major complications after surgery. And you can see grossly that as post-op complications go up, average charges per center go up. And Virginia and other places have published similar things on this. And the reason I show this is because I really think if ERAS is done successfully, we see these bars go down, which in turn would decrease costs. So those 3 things are kind of the 3 major reasons why Maryland, we decided to work on enhanced recovery. And then these are the 6 components of our University of Maryland Cardiac ERAS program. We developed these jointly between University of Maryland, St. Joe's, and PG County. And we picked, there's about 20 recommendations that you can go with for cardiac surgery. We picked 6 that we thought were both most fundamental and to some extent least controversial. Although number 2, definitely carb load, is very controversial. And even at the time we were doing it, avoiding the prolonged fast was actually controversial in the Maryland system. But we put it in there anyway. So we were developing this in April of 2018. And I'm just going to go over our components a bit. Patient education, something that cardiac surgeons and cardiac surgery programs have focused on since the beginning. But we realigned our patient education to be more specific for the patients before surgery and to align with our ERAS goals. We talked a lot to patients about ambulation and sinus spirometry. We told them why we thought a shortened NPO time was beneficial, and we talked to them about why we were going to give them a carbohydrate load before surgery. We talked to the patients about our opioid sparing approach and the benefits we thought they could accrue from that. And this was well timed with coinciding with our national opioid crisis, so it was a very well received message. We tried to make our program as patient-centered as possible, which I think is something we can all still work on. Certainly we can. But we put our new booklets before 2 patient committees before we even showed them to our own patients. And then we wanted from the beginning to have a digital interface with our patients, similar to the presentation that we just heard from Susan. And that is we've just achieved that actually this January because we were unhappy. Either all the products that we trialed were either way too expensive or we didn't think they would work well. But we've now just added that and preliminary results are good. So a similar question to Susan, we'll just go through it maybe more formally. Do you think digital applications are valuable in patient education and preparedness, as well as post-discharge? What do people think? Wow, that's great. So I could tell you a little bit more about what I found and we've only been doing it for a few months now, but how we prepared. But does anyone else want to share it looks like a lot of people probably have experience with it. Does anyone want to talk about their experience with digital interfacing with their patients? All right, I'm not going to pick on you, Kevin, if you're still there, because I'm going to save you for Prehab comments. I could tell you a little bit about what we did, and I don't have data to say it's successful, except for anecdotally, it seems to be working, and hopefully we will have some data after we're doing it for 6 months or a year. First of all, we also found Seamless MD to be extremely expensive. although they did have certain aspects of their product that looked good. We went with a product called Care First, which has been used mostly for orthopedic surgery as well. Their cardiac surgery application was not well developed. We had 3 of our providers go through the program before we offered it to patients, and it had a lot of bugs in it. And we worked with them for months, to the point, we deployed about 7 months after we planned to, because of all the kinks we had to work out, to the point where we almost ripped up the contract, actually. But the positive things that we found is that we have one NP that explains this to every single patient and enrolls the patient and a caregiver. It's always a patient and a caregiver, never just the patient. And they have the option to either get text, use a web-based application, or receive phone calls. And this product works pre-op and post-discharge. It doesn't follow the patients in the hospital, which is one weakness of the product that they say they're working on. So far, we've been happy with our level of enrollment, and anecdotally, the patients have found it useful. Let's see, we're stuck. Prehab. Now, we did not put Prehab as one of our components, but I wanted to talk about it. I think it is a fundamental component of ERAS. We didn't put it, even though I really like Prehab, we didn't put it in our program because I didn't think we had the infrastructure to have a complete Prehab program. So, so we left it out, but it is in a future state, we will have Prehab. Just overall, the concept behind Prehab is particularly looking at elderly patients and kind of, people say frail patients or kind of pre-frail patients, patients that are frail but not like severely frail, who are high risk for loss of functional capacity, loss of independence. And currently about 8.5% of the world population is over 65. In 2050, that'll double. Well, 1.6 billion people will be over 65. So it's going to be increasingly important, I think, in our specialty. Again, about the concept of Prehab, this solid black line is kind of business, kind of standard operating procedure in surgery in general. If you have a pre-op patient and then they have surgery here, this is kind of, think of this as a level of functioning independently at this dotted line. They fall below that level after surgery, then they get discharged to rehab, and they spend a period of time where they're not independent, and then after a while, they get out of rehab because they're now independent, and eventually they hopefully get back to their baseline level, and some patients we know don't really quite get back there. The concept of Prehab is to take those patients before you insult them and try to improve their baseline level up to here. So then when they get hit with surgery, they still drop down, but not absolutely as low. And then they spend their time trying to get back to their new baseline level, but most of that time is above a minimum level needed for independence. And that, from a patient standpoint, allows for them to get back to their normal lives more quickly and is a better quality of life. This is borrowed, or really stolen, because I'm not planning on giving it back to him, from Rakesh Arora in Manitoba. And he published recently on Prehab and uses the term the new rehab. And these are the 3 components that you should have if you're going to develop a Prehab program: optimized nutrition, optimized exercise or physical therapy, and then optimized worry or alleviating pre-op anxiety, and really ensuring there's some type of social network for the patient, some type of support for the patient. And this is everything we just said, and hopefully by getting our patients stronger before surgery, especially those kind of pre-frail patients, we can lower length of stay and decrease complications. There is actually a good amount of evidence regarding prehab in the non-cardiac population. The evidence in the cardiac surgery population is a little bit, this is one of the first pictures of the black hole from NASA. So it's not quite a black hole, but there's definitely very limited evidence in the cardiac surgery population that it decreases complications and decreases length of stay. There's a lot of enthusiasm for prehab, definitely an area that's ripe for research. I thought I'd go over a little bit of the evidence because there's not that much of it, so it won't take that long. This is probably the sentinel study from a group in Canada where patients were randomized to exercise in several educational sessions prior to Cabbage. And they included all patients, not just elderly patients, but they showed in this study decreased length of stay, decreased ICU length of stay, and improved quality of life for the patients up to 6 months post-operatively. And patients were more likely to enroll in rehab post-operatively, which we know has long-standing benefits for patients. So this is an extremely positive study, which I think strongly supports the creation of a prehab program. And this is a smaller study, but really a well-done study. And it's actually from several years ago. It was a pilot study in the UK where they took patients for 6 weeks prior to a Cabbage, and which is, I realize, a little bit long given the workflow in our country, but they had a home-based prehab program. Patients had like a couple of training sessions with a PT, and then they went home and did their exercises. And they only included patients who are high risk to be frail. So basically, I think it was patients over 65. And post-operatively, they showed the patients had improved 6-meter walk tests and decreased length of stay.
Dr. Salenger?
Yes. Oh, do we have a question?
Yeah, from Dr. Spear. Does Prehab use Prehab? Is it covered by CMS insurance? And what type of exercise?
Okay, let me, so the exercise, to be honest, I leave the exercise specifics to the physical therapist and the occupational therapist. And that part we've been doing the exercise part at our hospital for a while now. And I think they tailor it to the ability of the patients, but they do a lot of training with them pre-op, how they're going to be able to move. We do we've liberalized our sternal precautions so that they go over that with them. We do the move in the tube kind of sternal precautions now. So they train the patients how they're going to do their activities of daily living post-operatively. They prepare them. They talk to them about incentive spirometry, walking, and then I think they give them some strengthening exercises that are based on their individual abilities. And as far as the insurance question, so through the ERAS Cardiac Society, I've spoken to, there's a anesthesia nurse practitioner named Vicki Morton, who's part of Atrium Health, and I'm sure Kevin knows her better than I do, who told me that insurance companies do cover prehab, but she practices in the Carolinas. So I don't know if it's different state by state. I'm bad about insurance coverage. But that is clearly important if you're going to try to build a program that takes some resources for sure.
And I'm sorry,
Is cardiac rehab ever used before surgery for the prehab?
Yeah, we use our cardiac rehab. So what we have, a lot of places have, and I'm sure are similar, we have an active cardiac rehab program. So we don't have so much like the nutritional program or the anxiety program, but we have the PT and we use that. And in order to get it covered, so we do a steady score on everybody. And if they have like a bad steady score and they're an outpatient, then they'll get pre-op physical therapy. And there's some particular way you have to word the referral so that it doesn't eat into their post-op rehab. but I'm sure your rehab program can work with you on that. Our rehab program were the ones that pointed it out to us. Kevin, if you're on the phone, do you have any comments about prehab? Maybe not there. Do you want to do this poll? Do you currently have a comprehensive prehab program?
Would you like me to launch it, Dr. Salenger?
Yeah, let's launch it. Let's see what people have. Yeah, so what I would bet is that a lot of places are pretty well developed in the physical therapy arena, but not so much in the nutrition and anxiety arena. That's what it seems like talking to other programs. And I think reimbursement and resource utilization are the big issues with creating a really good prehab program. What I would love to do at our hospital is build really a pre-op optimization center for all surgical subspecialties, which is obviously a pretty big project that's not supported currently by insurance reimbursement.
Cardiac rehab does have psychological assessments, nutritional support, and might be well suited if it's something that would be covered, because they'll then recover and do their post-op cardiac rehab. I don't know if anybody has any experience using formally cardiac rehab as a rehab.
Yeah, I think it's a good, you're right. I think it's a good place to start. And you're right, they do actually have also nutritional classes and they do touch, I think, on all three, particularly in their post-op program, they touch on all three areas. It's a good suggestion. So our second component for our University of Maryland ERAS program was the abbreviated FAST. We actually made patients NPO 2 hours prior to surgery, and 2.5 hours prior to surgery, we give them a carbohydrate load with a complex carbohydrate drink, and we give them 30 minutes to drink it. At the time that we started, we were the only hospital willing to do a 2-hour NPO period, and we're still the only hospital willing to do the carbohydrate load, which I believe in, but I think anecdotally the experience is mixed. I think I have, so there's a meta-analysis, again, based on colorectal surgery, looking at the benefit of doing a carbohydrate load versus not. And this meta-analysis showed basically there was improved glycemic control, improved GI function, which is obviously a bigger thing after GI surgery, increased patient satisfaction, which seems to be pretty consistent finding. They had a decreased length of stay only if the length of stay was greater than 2 days. So really only for bigger surgery did it make a difference in length of stay. And all the trials were of low to moderate quality. So it's still, I think, a debatable point. And I believe that the improved glycemic control is probably one of the most debatable things. There was, let's see, in cardiac surgery, there's 2 studies that didn't particularly look at, they didn't look at carbohydrate load in particular, but they included carbohydrate load in their ERAS pathway, and they were ERAS studies in cardiac surgery. One's from China and one's from Wake Med from Judson Williams and his group, which I think has probably the best cardiac ERAS program, most well-developed program right now in the country. And they did not find increased incidence of hyperglycemia post-operatively in either case. There's a small study from Turkey that I didn't put up here, and I'm a little skeptical of it, but they showed less hyperglycemia, less insulin use with a carbohydrate load, and less inotropic use, which it isn't completely impossible because insulin can be a little bit of an inotrope for the heart, but they also use less insulin, so I'm not sure why they had less inotropic use. Yeah, I'm not sure I would advocate that, to expect that. Okay, so this, I think we may get a mixed response on this. Do you feel a shortened NPO time is beneficial for cardiac surgery patients? $60-40. Oh, that's pretty good. Yeah, I think that's exactly kind of the response I've seen even within our own system. Our hospital believes in it, but the data in cardiac surgery just isn't there to come down strongly. I believe, especially if you're looking at an afternoon case, keeping them NPO after midnight, I think is, I mean, when I have my cardiac surgery, I don't think I can go from midnight to 12 without food. So I just want to change it before I need cardiac surgery. And then we have a question about the carbohydrate load, which I think is even less popular. Do you feel that a carbohydrate load should be used for cardiac surgery patients? I don't know, am I allowed to vote? Oh, good. 60-40 the other way. That's pretty good. So again, this is something that is even less well studied than the shortened NPO period. And we really just need more data to see if this is beneficial. And the next question, even more we need data on, is do you feel that a carbohydrate load should be used for diabetic patients? All right, one person. So great. So 90% of people say don't use the carbohydrate load in diabetic patients. That is definitely a defensible position. It is not the position that we took. Part of the reason is I just wanted a standard process for a new program. But also if you look at the literature, there are several studies that included diabetic patients where they did not have significant hyperglycemia or any hyperglycemia. So we included them. But again, I think we need more study in this area. And then I believe we have here, these are VCSQI data regarding Cabbage patients at sites where you guys started carb drink. And the three groups of patients here: patients without diabetes, patients with diabetes, and patients with insulin-dependent diabetes. And this is showing their peak intraoperative and postoperative glucose levels. This is with the carb drink, and then next to it is before they started the carb drink. And pretty much for every group, the peak glucose levels were higher with the carb drink, intraoperatively and postoperatively. Post-op in the non-diabetic patients didn't make a big difference. Do anyone from either of these centers or from any of the centers have any comments about this or what they found?
Dr. Salenger, Mike Brown from Mary Washington has a question for you.
Oh, okay. I went backwards by accident. I was trying to answer a question. I can't see the question.
Oh, he's going to ask it. Mike, unmute your line. Let me unmute you. Sorry, I can't find your phone number. I'm going to unmute random phone numbers. Hopefully this is you.
Mike Brown. This is Mike Brown from where?
Mary Washington.
Mary Washington.
Mike?
Hi, this is Mike. Hi, this is Mike. Can you hear me?
Yes.
Yes.
So we actually started using the Abbott products last January with our ERAS program when we rolled our program out. Actually, we started our program in January and then of 2019, not 2020. And we started with the Abbott products, I guess it was maybe late February. And we tracked our outcomes with those products for about 9 months and went back and retrospectively looked at peak blood sugar in the OR and on arrival to the ICU, and then peak blood sugar in the ICU. And we had significant increase in blood sugars. In the diabetic population, we actually cut the bottle back the night before, actually both bottles in the days in advance, and then the morning of the surgery, we cut that bottle back in half, and then we discontinued it, I believe. But we had patients that were diabetics coming in with a post-induction blood sugar of many of them between 350 and some closer to 400. And I shared that information when I presented at the fall meeting, or September, maybe it was the fall meeting, how we basically had stopped we're using the Juven products for wound healing, but we stopped the Ensure pre-surgical clear just because we noted that. And since then, we've seen that our blood sugars have gone back down. We actually saw that in people who were, and by most definition, relatively healthy non-diabetics, were coming in with pretty high blood sugars, some of them well over 300, and we had them complete the drink within the time frame that Abbott had recommended. But I just wanted to share that with you, and I wasn't sure if you had seen those same results in your experience, and maybe you're using looks like you're using a different drink than we were using. But thanks for letting me talk.
Yeah, so we're using the ClearFast drink, which has maltodextran in it, and which I think the Abbott drink also is a complex carbohydrate, maybe have the same basic carbohydrate in it. I'm not sure, but yeah. So we definitely see some spikes, and we do see some high glucoses like pre-op. The nurses sometimes will check the glucose half hour after they drink it and report levels of 350, even 400. We implemented our ERAS program I wanted to start in January 2019. We started in February. And I haven't looked statistically at our peak glucose levels. Now, we do monitor our peak glucose levels. We monitor our peak intra-op glucose level on a dashboard that I'll show you later in the talk. And I can tell you that, we want the peak level to be less than 180. And I think in 20% of the cases, we're going over 180. I don't know how that compares to before the carb drink, but I think it's something we have to look at, and I believe it's an open question still. Anyone else have any comments? All right. So component number 3 for us was decreased post-op nausea, vomiting. And we did have some discussion about whether this was really relevant in a cardiac ERAS program. And I think it is. It's obviously it's probably more relevant in GI surgery. But, if we found that a minority of our patients were nauseous after surgery, and it doesn't just prevent them from eating, but it can prevent them from ambulating and prevent them from just meeting their milestones and getting discharged. So we decided to address it. It's pretty, it was pretty straightforward component. We give everyone 4 milligrams of Zofran when they get to the cardiac surgery unit. And high-risk patients, which is basically young females, non-smokers, young female non-smokers, or if they've had problem with nausea before, get this more expensive medication with their pre-med. And so that's that component, not as controversial. Intraoperatively, in general, when you're looking at ERAS in cardiac surgery, what you can do, multimodal pain regimen, guided fluid management, minimally invasive cardiac surgery, and immediate extubation. The one that you have to do, which is if you're going to do ERAS, is multimodal opioid-sparing pain regimen, and I'll show you what we use. It's similar to, I'm sure, to what other people use. Goal-directed fluid management, we did not put into our program because as many cardiac surgery programs, I think it's important, but we kind of already do it, you know, by looking at our SWAN numbers and already we try to minimize all the fluid we give at all times. I do think minimally invasive cardiac surgery does fit well into the concept of minimizing the trauma to the patient, so that if you can do it routinely and you have good results, I do think it fits well with ERAS. Immediate extubation, there are some people who are passionate about this. I'm personally skeptical about it, but I think it's an important area to accrue data. I know at Hopkins, if you talk to the team at Hopkins, they're very excited about extubating on the table. Our multimodal pain regimen is one of the biggest things we focused on in our ERAS program, and it's interesting. Part of our ERAS program was almost a request from the CSU nurses to use less opioids. And that's a little bit how the conversation got started. And as like many people, we use gabapentin and Tylenol around the clock. The gabapentin we started as a preload and quickly moved that to starting it postoperatively in the CSU just due to too much sedation. And we use a lot of dexmedetomidate. So most people just get these 4 things and a little bit of fentanyl on top. Ketamine is, I think, maybe not exactly unique, but the less usual aspect of our protocol is something I really like. We give a bolus in the operating room, and then we continue it postoperatively until they leave the CSU. Some people have to have it turned off because of hallucinations, but most people don't. We run it at very low dose. And it really decreases pain. Early extubation is step 5 in our ERAS program, and something that cardiac surgery programs have been focused on forever. One nice thing about ERAS in general is that I'll just point out what you're doing in the early parts of the program with patient education, talking about early extubation, using less opioids, maybe minimizing the trauma of your surgery, maybe even doing regional blocks. Those things all reinforce what you're trying to do later in your program. So that helps you with faster extubation and also helps you with earlier mobilization and ambulation, which is step 6 in our program, just mobilizing patients in general. We don't have a prehab program, but we do have a pre-op PT, OT program, which every inpatient gets, and some of our outpatients. We do PT and OT daily postoperatively. Our goal for ambulation is 3 times daily starting post-op day number 1. Our goal for incentive spirometry is 10 times a day, and we track it. This, by the way, is poorly supported to be beneficial at all by evidence. We've liberalized our sternal precautions quite a bit, and sternal plating is something that we don't use a lot. I'm the only surgeon at our hospital that uses it at all, but I think it's beneficial. I would use it more, except for the cost. And I think more studies on sternal plating, I think there's another area that is an opportunity for research. So question number 7, how many times a day does your program aim to ambulate patients postoperatively? Good. So 3 seems to be the norm. Some people are going for 4 or 2. And I could not find a lot in the literature about exactly how many times you should walk your patient after surgery. And I'm not sure it's critical exactly how many times a patient walks, but I did find this article, which I think was from 2017, looking at what they called high and low frequency PT or exercise therapy after Cabbage. And basically what they did was one group of patients got physical therapy starting post-op day 1 every single day, twice a day. And one group of patients got it once a day and not on the weekends. So between the 2 groups, there was a significant difference in the amount of physical therapy they received. The high frequency group hit their milestones earlier and had increased patient satisfaction. The study was not designed to look at length of stay, but you would think that if patients hit their physical milestones earlier, they would most likely be ready for discharge sooner. So this is just a follow-up question. Do patients receive physical therapy every day at your hospital, post-operatively? Good. So I think this is probably something that was true for programs prior to ERAS. I mean, this is something I think a lot of cardiac programs have traditionally focused on, getting their patients moving and building their strength. We did look at does anyone have any comments about physical therapy or barriers to physical therapy at their hospital? What about occupational therapy? Do people think that's important or not? So we had a couple of system-wide discussions. There are people that don't think occupational therapy is important. I really like it for our patients because they really focus on the activities of daily living, and they're really professional about making sure the patients are going to be safe, and I think enabling more patients to go home. So I really like the PT-OT combination. We looked at the barriers to ambulating our patients 3 times a day because we found out that even though we thought we were doing it a lot, we weren't doing it nearly as much as we intended. And we found that actually nausea was a common barrier, and patients being off the floor for tests like x-rays and things were probably the 2 most common barriers. A little bit about implementation. So we have an integrated care, like an integrated cardiac surgery care team that meets once a month. It's every provider in the hospital or representative from every team that interacts with cardiac surgery. And from that team, we created a core ERAS team. And I put kind of the people on the team up here, not so much that this is what you need to make the team, but just to show that I think this team looks different at every hospital. And you have to look at your local talent, and there are roles of people who could be on this team who aren't on the team at our hospital. And there's people on this team that don't need to be on at your hospital, because it depends who's passionate about it and also who kind of controls things at your hospital. So we have a surgeon, we have our service line administrator. We're very lucky to have a nursing director, which is kind of the top level nursing under the CNO. These 2 people are critical. Our 2 central nurse manager, which is our tele floor, and our CSU nurse manager. We have an advanced practitioner. This physical therapist, Rachel Bourne, has been outstanding on the team. We have someone from our transformation office who is a nurse. But the transformation office kind of is our statistical area. I mean, I would love to have a biostatistician, but unfortunately they wouldn't let me hire one. And we had 2 people from IT who were dedicated to ERAS for a long time. and we lost both of them because one of our hospitals was going live with Epic. So they're gone. But that is great if you can get it. You'll notice one thing we don't have is a ERAS coordinator. And some people can list that as a barrier to starting a program because that's a position that you need to get funded. I think there are clearly programs that have ERAS coordinators and they work great. Wake Med has one and their program is outstanding. I actually prefer not to have an ERAS coordinator. What I like to do is to take the power grid or the infrastructure that exists at your hospital and get those people to be the champions and to own the ERAS program. The nurse managers are key because what you want, your nurse managers and your nurse practitioners, if they're passionate about it, they get the nurses and the physical therapists and the respiratory therapists to own it. And if your frontline staff owns it, then you'll be successful. If they don't own it, it's not going to work. So to me, bringing in a new ERAS coordinator that people didn't know wasn't going to help if people weren't going to be passionate about it. This is a timeline of our rollout. Just to show you it took us about 10 months to plan our program, and I've heard from other people that sounds about average. First thing was, really we started talking about this in April and May, and then in July 2018, we had realigned our educational materials. We had realigned our order sets to specifically address our ERAS goals. We had created 2 dashboards to audit both our compliance with our protocols and look at our outcomes. And the goal for this, we didn't have human resources to walk around with clipboards and manually collect data on how we were doing. So we had to get IT to help us build dashboards that would automatically populate from Epic. And this should be something that it really should be easy, but it's incredibly difficult. And we'll talk a little bit more about that later. It's one of the biggest challenges, I think, regarding EHRs and definitely regarding ERAS. Training frontline staff and providers, I found this to be probably the most enjoyable part of the whole thing. We gave our nursing grand rounds as a group. We had unit-based meetings. We answered questions. It was great. And the staff was so unbelievably receptive. And then we went live February of 2019, which was 1 month later than I wanted to, mostly because these dashboards were so difficult to get working. And then data review and continuous improvement is something that we haven't completed. It's obviously an ongoing thing. And it's an area that requires refinement, certainly at our program. This was our first dashboard that we created. This is in a software called Tableau, and it automatically generated after the patient was discharged, so it couldn't really help you while the patient was in the hospital, but it showed us kind of it was a combination of kind of process metrics and outcome metrics. So it showed us length of stay, how many times people used in-center spirometry, and it was either green, yellow, or red, depending on if it met the goal. It showed our total narcotic dose for our patients and milligram morphine equivalents. I don't know why that advanced. It showed post-op nausea, extubation times, prolonged vent, some blood utilization metrics, which we take very seriously, ambulation by post-op day, and pain score by post-op day. So this was helpful, but the problem with Tableau is the data could not be filtered. If there was a problem with it, we needed to work through an Epic team, which if you've done that, you know it's unbelievably slow. We also had this patient list tool, which was real time. So on your list in Epic, when it came up, you could see how many times your patient had ambulated that day, how many times they'd used their spirometry, if they achieved early extubation, if they'd been transfused. We could not get the real-time milligram morphine equivalent, so we just settled for listing their pain meds. This I thought was fantastic. Problem is, I may have been the only, not many people used it for some reason. So what I ended up doing eventually, we still have those tools and we still look at Tableau occasionally, but it's hard to vet the data. So I ended up talking to my SDS data manager, who they just seemed capable of doing anything. And I showed her these process metrics. And so what we created was a process metrics dashboard, similar to our outcomes dashboard for cardiac surgery. And she agreed to manually go through the charts and collect this data, which we started doing a few months ago. And so every one of these process metrics is based on an ERAS cardiac recommendation that you should screen the albumin pre-op, you should look at A1C, was the patient MTL less than 4 hours, did they receive a carb load? We put things on here that we're not currently doing, like prehab is 0%, but things that we want to do in the future. We are doing 5-meter walk tests to try to classify our patients as frail or not. SSI bundle is 100%. Extubation time. And then the other things that we don't have yet are our intra-op milligram morphine equivalents and our post-op milligram morphine equivalents and discharge. We have delirium screening. Ambulation TID is 80%. So 80% of our patients are walking 3 times post-op day 1. When we first checked this number, we thought it was 90%, and it was like 23%. We had a meeting where our nurse manager from telemetry almost became despondent because she was so upset with that number. But then we were able to identify some barriers. And 100% of our patients get their opioid-sparing multimodal analgesic regimen. So we look at 2 dashboards now in our cardiac surgery meetings. This ERAS process metrics dashboard, but this in and of itself doesn't mean your patients are doing well, obviously. It just means you're following what you think is a good idea. So we still look at our outcomes dashboard, which we've morphed a little bit in the last year. This is kind of our traditional STS outcomes, right? So we want all this ERAS stuff to decrease our major morbidities. Don't look at our AFib rates because they're the highest in the world. We look very much at blood utilization, as I know a lot of the centers in Virginia do. So we put that on our outcomes dashboard, even though it's technically not in and of itself an outcome. We also put our length of stay on the dashboard. So we have some length of stay metrics and our readmissions. And then we put some cost data on the dashboard about our direct variable costs, patient satisfaction, and staff satisfaction, which we don't measure yet, but I want to. And then it's just our discharge medications like everybody else. So that's the primary way we're looking at our results now. And I'm stuck on this slide. No, I'm not. So ERAS barriers. This ERAS barriers in and of itself is almost a talk, but just to highlight the most difficult things I think about starting an ERAS program, the evidence is kind of, especially in cardiac surgery, is low to moderate quality, and there's not that much of it. So you kind of have to believe in it. You have to extrapolate the evidence from other specialties. Some of that is very strong. You have to get stakeholder buy-in, and you have to deal with physician preferences, especially if you're at a large center. This is very difficult. And these 2 things are kind of similar. And stakeholder buy-in, you know, the best thing that we were lucky at our place that the nurse managers and the nurses on 2 Central and in the cardiac surgery ICU really just bought into this right away. And so did our physical therapists and our respiratory therapists. I think if you get your frontline staff to buy in, then you're going to have a very successful program. And that is clearly related to dissemination of knowledge. You have to spend time talking to people. I talked to a million people about this, why I thought it was a good idea, how I thought it could help our patients. And then when you go to implement, you have to have standard work. You can't have everybody doing it their own way. You have to have the frontline staff really owning it, understanding it, believing in it. And then clearly you have to monitor and audit your results and allow some feedback and be a little bit flexible, because your first attempt is not going to be the perfect attempt. I'm going to share with you a little bit about our successes, and then we can talk some more. This is an abstract from here, from St. Joe's, where we looked at just after 3 months of ERAS, we looked at our opioid use in the first 24 hours after cardiac surgery. And as I talked about, this was mainly, the reason we looked at 24 hours because we wanted to see particularly highlight the effect of ketamine, which we use as a continuous drip. And we found there was about 70 patients in our post-ERAS group, about 56 in our pre-ERAS group. And we found a statistically significant difference in the amount of fentanyl being given in the first 24 hours and a statistically significant difference in the overall milligram morphine equivalents being given to our cardiac surgery patients. Wake Med in their one-year publication found also a significant reduction in post-op. This is also the first 24 hours, 40% reduction in post-op opioids. Wake Med also found a decrease in their ICU length of stay, which was about 15 hours, and in their overall post-operative length of stay, which was 1 day. We just last night, I was looking at, we're getting ready to try to publish our one-year data, and we saw what looks like is going to be a statistically significant difference in our overall post-op length of stay, which I was a little surprised by, to be honest. And I'm not sure. We see either a strong trend or a statistically significant difference in our ICU length of stay as well. We don't have our final stats in. We have to show the data to our statistician. But I was excited about that. And our opioid use is unbelievably decreased from before ERAS. This is length of stay data from Johns Hopkins. And this is from Mike Grant and his group. Mike is very knowledgeable about ERAS and has published a lot. And this is interesting. Hopkins is a very organized, across all their specialties. They have a very strong ERAS movement. And what I heard from someone is that they did not see a decrease in their length of stay in any of their service lines. And that was true in cardiac surgery as well. But what Mike did, Hopkins is also very intelligent. And what I would have never thought of this, but Mike looked at the difference in, Mike looked at the difference in length of stay according to compliance with the ERAS protocol. So this dotted red line are patients who complied with 5 to 7 process measures versus patients who were non-compliant with the protocol, 0 to 4. And he actually demonstrated statistically significant decrease in the length of stay if you are compliant with the ERAS protocol, which I thought was a pretty good finding. I love this graph. When I first read this, I was highly skeptical, but then I saw the same thing at our institution. This shows staff satisfaction at Wake Med, at Judson Williams program. And this line in the middle is where they implemented ERAS. And it shows staff satisfaction going up significantly after ERAS was implemented. And it's actually true. We don't have data in our program, but I can see it on the floors. You go back to the staff and you show them the difference that they're making for these patients, and people love it. People are into it. They have more suggestions for you of what you can do to make the program better. It's really enjoyable. Future directions for ERAS, I think these are areas where I think we could see a lot of good research being done. I think delirium is a huge opportunity in cardiac surgery. It's obviously a very difficult subject that we've tried to tackle before, but progress made in preventing and treating delirium could really help our patients. New persistent opioid use, Mike Grant's group has published on this after Cabbage and valve surgery. It looks like it's about 5 to 8%. We have a little bit of data on this from our program as well. And I think this is an interesting statistic for cardiac surgeons to be aware of. Nutritional assessment and support is ripe for research. I personally believe sternal plating, I believe the price point is a little too high, but I think that there may be a benefit. I think it's a much better solution for a fracture than wire cerclage. And I think more data could help convince our community that a little bit more initial output of money may be worth it if we can show clinical benefit. And then you know, working in shared decision-making, especially as our patients get older, and making sure that we're helping them achieve the goals that they want, and that the benefits of surgery are really things that they find valuable. So in summary, I spoke a little bit about why you should invest in ERAS with your time and thought and energy, the components of our University of Maryland ERAS program, some of which I think are universal to any ERAS program, a little bit about implementation, and shared with you a little bit about the success we've had in cardiac surgery in this country. And I'm welcome to any questions that people have.
Dr. Salenger, this is Eddie. I have one question with regards to rollout of your ERAS program. So you had mentioned it took a number of months to prepare the different components of it and assemble your staff. But for a couple of our programs who mentioned that they are in the process of implementing ERAS, did you guys roll out all 6 of those components you mentioned at once, or did you do them kind of step by step in terms of the different pieces? How did that work exactly?
That's a good question. So we, you know, I wanted to try to, in the back of my mind when we were rolling this out, was I wanted to be able to tell if ERAS made a difference, because I really believe in ERAS, but you know, cardiac surgery is already so quality improved as it is. I wasn't sure if it was going to make an additional difference. And I still think it's an open question to some extent. And so I actually believe strongly I wanted to roll everything out at once and have a point that we could compare to say this was ERAS. And then we actually go back, we leave a little buffer zone and say this was pre-ERAS. And to the point where the core ERAS team, I wanted to start educating people in the summer. And the core ERAS team said, no, you can't start educating people, because educating people about ERAS is ERAS. So we didn't start educating until January. That's when we did like an educational blitz of the institution.
Okay. Dr. Salenger, Dr. Alan Spear has a question for you.
Ron,
Yes.
thank you very much for your thoughtful, organized, and eloquent presentation. Your enthusiasm and for this subject is totally understandable. But more importantly, you're obviously very committed to it. And not to be biased, but I've had some reluctances around the different aspects of the ERAS program that you have discussed, and that's more of my individual bias, particularly around the carb loading, than perhaps there should be in a more openness, particularly with that incremental small step, 1% steps that shows the aggregate improvement. You went through the results pretty quickly, and at least what I could see, the things that we are used to measuring in cardiac surgery, which are pretty gross, really, mortality, morbidity, the different post-operative findings, that you have to have a relevant number of them to really make a difference. But I didn't see a big impact overall. I may have missed it because, as I said, we didn't have time to study it much. But obviously the opioid point is huge, particularly in this day and age of seeing our addiction, our parenteral addiction, going up by 400%, and perhaps this may make some impact on that. Who knows? Because we're seeing so much endocarditis now. But the thing, my takeaway, beside the small incremental steps that you showed, was the preoperative physical therapy and how that absolutely changed the perioperative convalescence and postoperative experience. Are there other sort of areas, and you covered them, but it was sort of overwhelming. Were there other things that you look to that you really are the proudest of, that you can say, you know, that was a good thing, that we should have done that sooner? Thank you again for being with us tonight.
Yeah, good question. I mean, the thing that I want to see the most but I was skeptical from the beginning, and we haven't seen, is a decrease in our major morbidities and mortality. We haven't seen it. And I'm just not sure if we can. Now, I think prolonged vent maybe eventually, and early extubation we'll see an improvement in, although we haven't yet. We've seen a huge decrease in our opioid use, which is not in and of itself an outcome measure, but I think it's allowed us to get our patients more mobile, and it's why we're seeing a decrease in our length of stay, and we've seen a decrease, statistically significant decrease in our length of stay for Shor. I'm not sure if it's going to be statistically significant because we're still analyzing our own results, but we've seen either a strong trend or a decrease in our ICU length of stay, and we've seen a decrease in our readmission rate. So those things I'm pretty happy about. And our intensivists I'd like to get our early extubation rate up to 90%, which I know a lot of people say it's not a quality metric, and that's true. But I think it's an efficiency metric that I want to see in our program, help us move people through quicker. And I think that'll help us continue to move the things we're already moving, and also increase patient satisfaction. You know, the faster you move people through the process, as long as you're responsible about it, patients are happier in general. But we haven't seen an improvement in post-op, stroke or bleeding or renal failure, things like that, or mortality.
Are you one follow-up question, if I could? Do you think that we're in a position between our two societies, our two initiatives, to maybe look at some of these data jointly and share some of this with the eyes to sort of what is our next level of outcome measures? We're sort of caught in the square corners of the Society of Thoracic Surgery National Cardiac Database, but given the overview of mortality, morbidity, and knowing what we're up against with that, are we at a place to start looking at the more subtle or softer findings, as you've suggested, as sort of what's our next challenge you've suggested? Because all of those play a role in how the patients view their hospitalization, not just from satisfaction, but also their return to work. So, the ICU length of stay, the patient satisfaction, the opioid use, all these things that aren't being measured objectively yet, but we know in our hearts that it's the right thing to do. And is that something that we, with the volumes of the two organizations, that we could show an impact that is different than just our standard mortality morbidities?
Yeah, well, I can tell you that is great. I would love to do that. I think there's definitely opportunity to find more patient-centered outcomes to look at, things that are important to patients that we're not measuring. I'd love to explore that. There's people in MCSQI asking the exact same question. So I think it would be great if we could get together.
Thank you again.
Wonderful. Thank you so much, Dr. Salenger, and we will look forward to future collaboration between our two groups.
Great. Thanks. Thank you so much for having me. I'm really honored to get to talk to your group.
Likewise, we would love to have you again. Hopefully, when we're in person next time, wherever that might be.
Thank you, Ron.
Thank you, Ron.
My
Let
pleasure.
me know if you use cardiac rehab as a prehab.
Okay, I will.
For our next talk, I will introduce Gyula Sziraczky, the president of ARMUS Corporation, who is our longtime database vendor. Gyula will present some updated clinical financial reports primarily from our cath-PCI data set, which is a new linkage that Gyula and the ARMUS team have just pioneered here with our database. So Gyula, I will pass you control of the screen. And You can run through. All right, you should have it now.
Thank you. How much time we have, Eddie? Because we are out of time. So it's supposed to be much.
Well, we're running a little late, but I think we should
Okay.
still run through the slides as best we can, Gyula. Okay.
So hi everybody. I hope everybody is in a safe place and taking care of himself and herself and the family. So it's a crazy time. What I would like to show you quickly is the kind of direction which we are started to go, at least looking at the data from a different perspective in cardiac surgery. But first, I would like to go through some preliminary result of the CAPE-CI clinical financing finding. It is very different. The data set and the database is very different than cardiac surgery, as you probably know, because of the structure of the database and the data. It's very, how can I phrase this? It's a little bit difficult to find a view of the database to pair it with the financials and create a really truly accurate presentation. What you're gonna see here is a first very serious attempt to dig into this massive amount of information and trying to figure out some issues and providing you to ask questions. So please do. It is really the beginning of this research and understanding. I strongly believe we can apply some machine learning relatively soon on this, but we just wanted to have a first few steps before we start running. So I don't know, Eddie is not. Oh, I have to go down here. Oh, I'm sorry. Okay. So this is a time slot of showing the data from 2010 to 2017 on the matched PCI cases only, and it shows some kind of reverse trends between the femoral and radial approach. And I did this because Eddie asked me to focus on this area in medicine, I mean, in cardiology. So we did this, and so as you see that the femoral approach and sites are going down and over the years, and radial is moving up. This is a slide which is focusing on in-hospital mortality, comparing the femoral and radial approach. Again, you can see the range here. You can see the cases, CAPE-CI only. The charges and the cost are median. The denominator, when we calculate the percentages, are all cases. And ratio to cost to charges are 29%, which is the average based on the cardiac surgery experience and data. So here you can see the femoral side, the number of episodes up to from 1 to 4, and radial is 1 to 3. We couldn't find any episode where there's more than 3 cath lab visit or episode of care was in the same admission or any admission for patients in the database at this particular time. And so you see the no hospital mortality segment here shows the number of associated with the number of episodes and the calculated cost. The red is showing if the median cost is higher on each side. As you can see, the femoral area, the no hospital mortality rate slightly higher. But if you see the charts here below, the bars, there's not much difference compared to the in-hospital mortality area, where the difference is relatively high on the cases where the patients have 2 episodes of cares. And we also recognize the missing values here. But it's interesting to see that although the costs are not much difference in these particular two groups of patients and cases, the end result, the quality is definitely different. And as you can see, the percentage without and with the missing data relatively similar and much more favorable to the radial approach, at least in the mortality area.
Gyula, can I stop you on that one real quick?
Sure.
I'm sorry. Looking at patients with no mortality versus where they have a mortality, it seems like femoral is more expensive when there are no post-op events, but then when you have a post-op event or when you have an in-hospital mortality, radial becomes more expensive. Is that because of outliers, or why do you think that might be?
It's probably outliers. As you see, the number of cases here are definitely much lower in the area of 3 and 2. As you can see, this is only 4 patients, and these are only 922. I mean, it's 922, so maybe the outliers are really, give you a much more larger spread of information. But yeah, I recognize this, but we are talking about only 4 patients here. I asked Sheila about this. She's our domain expert, and she said that many times at the cath lab, they do everything is humanly possible to save the patients, and that became a costly option or procedure. So, I'm sorry. Something happened here. You can still see that?
Yeah, go ahead. Sorry, I had to give you control back.
Okay. We can see the slide.
Okay, so this is the acute kidney injuries, same scenarios. As you can see, the charges at the no area is relatively the same, except in these places where you have 3 episodes of cares. I think it's because of the very low volume. That's where you see the differences here. And it's a little bit of the opposite direction cost-wise when you're looking at the kidney injuries observed cases towards the femoral area, femoral access cost much more money. And as you can see, there's differences between the percentages as well, again, favorably to the radial approach.
I think Dr. Spear has a question.
Gyula, I'm sorry, I was fumbling with my computer and I didn't ask it on the other slide, but it seems that the in-house mortality, that we're sort of getting caught that the radial versus femoral is is there an association? We're seeing the disparate cost, as Eddie pointed out, between those without mortality, which is a cleaner set because you could sort of balance those because without the distraction. But at what point does the access sort of default to the complications? Obviously, the mortality is sicker patients that are going to have more complications, more peri-procedural morbidity, and that truly the approach, the catheterization approach, may have nothing to do with these findings. And so how do we, maybe the interventional guys in the room could, or on the talk could weigh in, but how do we correct for the complications that are increasing the cost and not the catheter approach that we know has merit in those no hospital mortality group?
Well, I mean, this is really, as I mentioned, that Dr. Sherri said, really just the beginning of our mapping, first of all, the patient population into groups and figuring out what's going on. The clinical evaluation, if you're referring to that one, was not part of this this presentation. It just, as you can see this here, it just shows the difference of the two approaches. I'm not really domain expert of interventional cardiology and I guess especially with PCI. So, but these are the issues which I hope that's going to come up, so can help us to go to that direction. And also would like to mention that is this particular subject here is a very, very good and promising subject for machine learning, and we are setting up the environment to be able to do this, to figure out what the differences are here. But again, I would like to focus on the really low number of cases here, like 4.
Yeah, this is Bob, but just to chime in, I think the N being so low really throws into question the value of that number, and I would not focus on that number because it's probably distorted by 1 or 2 cases, and the N isn't big enough.
Yeah, again, it's just the findings, and this could lead us to some, different kind of grouping the patients, different kind of extraction, and focusing on a number of episodes, 1, for example, because that's dominating the 2 studies, is right, and then move on to that direction and dig deeper into the subject. This is just informative. What's in that set of data which we were able to match clinically and financially. I remember that at the beginning for this study, I'm sorry, just in 2019, we had very small number of patients at the beginning for this.
Gyula, comment again on the missing category. What's missing there? Is it just some of the data, or
missing
we didn't know
about,
if it was femoral or radial, or?
No, missing of hospital mortality, indication of hospital mortality. So that information is not there in the database. Okay. Anything else there? No. So that's the acute kidney injuries. Again, we can focus on just the larger groups in the future and figure out what's going on here. It doesn't really, have any kind of major problem here. Beside this, again, there's just a very, very few cases here indicating that the higher price cost. The next one is bleeding. That's very interesting. You see that, but the cost difference is not much until here. The 2, but that's again, it is the lower group of patients compared to 4,642, 884 for the first one. So again, we just run into this and did this in a very, how can I phrase this? Just from the surface to make sure that the data is correct, make sure that the patient's population is matched. I cannot tell you what is the matching rate. I think it's a lot of places where we have, for example, social security number 7 or 8 exact digit, like 888888 and 0000. So those cases are out. So a lot of cases has to be thrown out for the first run because those social security numbers are not available to match. This is based on only that one. The VCSQI cardiac surgery program has a much more sophisticated algorithm to match the cases because of the social security is not available at all. And so we had to build a very extensive and very detailed and sophisticated set of algorithms to match the population up to 99.7 or 97 point some percentage rate. This is not there at all. So we have to work on this much more to reach that kind of level. Okay. That's the cost of having a patient having a prior Cabbage before the PCI. It's interesting that no prior Cabbage seemingly have a much higher cost. So that's an interesting observation, which you can see here, which we need to investigate. and any kind of clinical advice would be really welcomed here. So what do you think is happening, and is there another rationale here or not? No? Okay. Next one, emergency cabbage cases. You can see the difference is much higher for the emergency cases. And p-value is 0. So this is, it's run a different kind of statistical package to figure this one out. Now this is interesting. So here's the appropriate use qualification. As you know, that there are not just 3 but multiple, more than 3 categories, but we are just focusing on here at the appropriate, maybe, and really appropriate cases. You see that there's not much, the percentage of the cases are relatively low. But if you look at the associated cost for these 2 categories, which represent only 2.6% of the 16,000 patients, it's $11.5 million. So, you know, it's interesting to see that from this perspective. And so we don't know where is that happening, which hospital, and who's contributing this or who's not, but that's just an observation point again. Okay, so cardiac surgery quickly is just a very simple approach to look at the data differently and focusing on where the cost saving could happen. And this is distribution of the mean of the 95 percentile, meaning that the average cost here is belong to the 95 percentile, meaning the 5% of the cases. And it shows that how does it varies from over the year. The gray is the baseline, meaning is here cases without any postoperative event or mortality. The major event is the STS standards, which is cases only following cases with only the following post-op event: mortality, prolonged vent, re-op, stroke, renal failure, deep sternal infection. And then the next one is all the events, post-operative events. So you can see the variations over the years, but equally showing that the cost of complications are very costly, and especially 95% of cases, you will see that the 5% of the cases, you will see the numbers there later. That's the 75 percentile. The 100% is the mean value here, so it's a little bit over the everything. And then the 25 percentile, you can see that's it's interestingly just leveraging out. So the low cost cases are relatively the same. So this is turned it into dollar figures over the years. So baseline again, start from the 5 percentile, the median 75 and 95 percentile of the mean, the median values. As you can see, that major post-op event very expensive. This is 2009. This is 2010, 11, 12, 13. So it's going up. There's a break here. And this is the overall look for 10 years. And you can see the trends definitely showing that the very few percentage of the cases contribute a lot to cost. So maybe it should be the analytics and reporting and quality measures should focus on those areas where these costs and complications and events are happening. I think that's what, and okay. And that's the curve. You can see that And Eddie pointed out that it would be interesting, and we can work on this to figure out the total value, amount of money on this particular area and how much it's going to cost for the system.
Right. So the area under the curve on this one, I think, would represent the summation of costs. So
Yeah.
even if it's a very small sliver in that 95th percent range, just look at how steep the curve is there. So there's going to be a lot of area, almost equivalent to the first maybe quartile or so.
Yes, yeah, absolutely.
Dr. Spear, go ahead.
Gyula, it looks like something changed in 2016. If you took out 2016, that it's not going to be that variable. But
yeah,
looking at the major events, is that a coding? Did something change with coding? Was there some methodologic thing that we did differently? Because otherwise, the major events have all remained about the same as were, regardless of the percentiles.
Yeah, I recognize
that.
that.
Changed the whole subsequent downstream graphs. So,
I mean, there is a slight, I'm sorry, there is a slight increase from 13 to 14, 15. This is absolutely an outlier, as you can see there. And in this, which one is that? This, that 16. So we can go back, I can go back and check the numbers and not just the numbers, what's happening there. And maybe the RCCs, who knows? I don't know. That's every year the RCC is uploaded and updated, and maybe there is the significant change of the RCC values reported by the hospitals.
I know there was an STS change somewhere. I don't remember the exact date. Our good quality people probably know that better. But I would suggest that's more of a methodologic issue. But just so that doesn't screw us up, we need to make sure that's not a bias to what it is. So
okay,
thanks.
The filters are incorporated. The version changes are incorporated into the major event, because you're right, there was some changes. I don't know, maybe somebody knows where was the 2.81 to 2.9 change?
2017.
17, yeah, that's what I thought. Yeah. But again, we can check this out. I just wanted to get to this point and check this out per individual hospitals in VCSQI and see where the real outliers, and I'm more than happy to do that. But also, I would like to suggest, as we talked about this a couple of meetings ago, to move into machine learning and figure this out. So Eddie and I talking about to put together a proposal for the board to allow us to do this in a much larger scale, to learn much more insight of what's going on here. I think we have plenty enough data available in VCSQI to do a very significant study. So with that, I would like to give this back to Eddie, and thank you again, and hope everybody gonna be safe and healthy.
Sounds great. Thank you so much, Gyula.
You're welcome.
And I realize we're running a little bit over on our estimated time frame here. I'll run through my slides pretty quick, and then we will distribute these out to everyone afterwards as well. But this is meant as a look at a few of our newer ongoing quality projects, including the ACE angiogram reviews, our latest look at cath PCI, as well as the VHI and the all-payer claims database that Dr. Shor mentioned earlier. So our VCSQI strategic plan. This is the ACE process. For those of you who aren't aware, it's an external angiogram review company that we're partnering with to take a random look at 5% of our PCI cases, meant as a proactive approach for ensuring quality. At this point, we've done reviews of 4 centers of their data within the last couple of years. So we have right now 2 different pools of patients we can compare against one another. The baseline from 2016 and then 2018, 2019 combined for 4 centers. Overall here, we're looking at just under 300 patients and just under about 500 lesions, of which 314 were treated. And there's about a general 92 to 93% success rate of those lesions that were reviewed. This is a little pie chart breakdown. Again, 92 to 93% success. The biggest piece we wanted to look at in terms of the angiogram reviews was what happens when a lesion is less than 50% and it is treated via PCI. So from 2016, our initial data showed that almost 18% of lesions less than 50% were treated. That improved dramatically in 2018 and 2019 to only 6% of those lesions that were treated. Of those lesions, about 90 to 92% again were successful. So it didn't matter whether the lesion was less than or greater than 50% in terms of success, but the overall proportion of those lesions decreased over time. And we can see that a little bit more graphically here from, again, 16% of patients with 1 or more lesion, less than 50%, decreased down to about 6%. And the percentage of total lesions went from about 18% down to 6%. I'll briefly pause. Any of the centers who have undergone their reviews want to share their experiences and how this has changed your practice? And I see Dr. Spear has a question too.
No, I don't.
Oh, your hand's still up here, huh? Okay. All right, well, this is an ongoing process with regards to ACE, and we do have a couple more sites in the queue. So we will make sure to provide updates at our meetings, and we've been working with our data managers group as well on this. With regards to cath-PCI, this is an update of a slide deck we've presented a couple times now. This is similar to Gyula's slide in terms of femoral versus radial breakdown. For the last 4 quarters of cath-PCI data, this is excluding concomitant Cabbage. Femoral radial access by site ranges really from about 10% to 90%, depending on whom you're looking at and the volume grouping within. So still just a ton of variation in this metric. Next, we ran some of the outcomes. This is overall observed bleeding, again, for all patients without Cabbage. And then we broke this down by access site as well as by volume group. You'll notice here that the different trends, radial generally is 2 to 3 times less than femoral, which is pretty similar to what we had seen previously.
Yeah, I just want to comment that if you look on the left, the percentages are dramatically different. So you just have to be careful when we're looking at that, because radial is less than 2% often, and 4 to 5% femoral on average.
Thanks, Dr. Shor. Pretty similar story for a number of the other outcomes metrics. This is red blood cell transfusion. Again, we have different axes between the 2 views here. Fluoro time. The low volume centers, interestingly, are very low for both radial and femoral access. And AKI was a big piece we discussed last time as well. This is, again, all PCI minus Cabbage. And the high volume centers seem to have a pretty significantly higher rate overall than the low and the medium centers. This might be a measurement piece though, in terms of who's getting their creatinine drawn more, more consistently. And lastly, this is observed AKI by axis site. So again, pretty different between radial and femoral here. Our last set of PCI metrics are actually combined with some of the Cabbage data from STS. So right now we have 8 centers who are submitting both PCI, cath PCI and STS data to us. We took a look at some similar metrics between the two types of procedures for 3 groupings of patients. The first is, like we had in the previous views, PCI without Cabbage. The next is PCI with Cabbage, and the last is just our isolated Cabbage patients. So our first view comparing the 3 sets of patients is red blood cell transfusion. This is any intra or post-op red blood cell for Cabbage, and this is just any red blood cell as far as cath PCI. On this view, I believe it was 4 centers had higher rates for the combined PCI and Cabbage, and the other 4 had higher for isolated Cabbage. Next, we ran a similar style of chart for acute kidney injury. This is using the cath PCI definition of either a 0.3 milligram per deciliter rise in serum creatinine or greater than 50% increase. So it's much more stringent than the STS definition, which is really more of a renal failure. So on this, the isolated Cabbage is still higher on 4, and then your PCI and Cabbage is higher on the other 4. Go ahead, Dr. Spear.
Eddie, that didn't make sense to me. On that last slide and this slide, if you've got, like, look at the first hospital, the 4231, how, or the second BKOW, if you've got the PCI without bypass and isolated bypass in the same hospital, and look at the low rates, but then the PCI plus bypass, it's more than twice, it's about twice. Wouldn't they be additive? I mean, wouldn't you have PCI and then with the isolated bypass be, and then the PCI plus bypass be the total of those 2 in the same institution?
No, because we've separated those groupings of patients. So if a PCI went on to have a bypass, they would only be represented in that blue group. There's no overlapping between the patients.
Okay, so in the same hospitalization.
Correct.
Okay. It looks like the N must be pretty low also because when you look all the way to the right, the VCSQI totals are much lower than some of those that are particularly high. So the N's in those institutions must be lower. Did you divide these up by low, moderate, or high programs?
Most of these are either moderate or high, just because they have access to Cabbage.
Right.
But good point on the volume figures here. There were a pretty low proportion of cases who had PCI and Cabbage within the same admission. I think it was less than 1% or about 0.5%. Dr. Shor, these were some of the discussion questions you had submitted prior to our meeting. They go in depth on AKI primarily. I don't know if you wanted to cover any of these as far as asking the group their thoughts.
Yeah, so as we go through the data, and I know it's late and we're actually past our time, but as we get these emailed to us and think about it, we'll need to start looking at the time between PCI and Cabbage and whether there were things we did, either purposefully delayed surgery to allow rehydration and correction of any elevation in creatinine, whether timing made a difference, how many had permanent kidney injury, how many went on to the dreaded dialysis, and then looking at what those cost implications are, which might be either of the complication or potentially of the delay in surgery to potentially avoid the complication. So just some thoughts to think about as we move forward in looking at the data. I don't know if others had other questions or comments about those, but if you do, please let us know and we can start looking at these more critically.
I have a very, very quick question, just I understand the time. So my understanding and my recommendation that Cabbage, cardiac surgery analytics is relatively simple compared to CAT-PCI because of the structure. And the clinical knowledge in the CAT-PCI area is essential for us to do reasonable reporting and study on these two groups. So we need help, at least on my side, we need help from you and the cardiologist, interventional cardiologist, to tell us certain kind of clinical criteria, as you mentioned just a few seconds ago, and make sure that we are not combining certain things which are not supposed to be. So we need directions here.
So what I would recommend is either if you know what the questions are, you can ask us, or we can sit with you as you're going through it, posing the questions and try to work it through. Because I agree, for this to be valuable, we have to make sure that it's validated and the questions we're asking are actually being answered.
Absolutely. Very, very difficult area. All right.
Thanks, Gyula. And we'll invite everyone to participate in our data review task force as well, which Sherri skillfully spearheads. We have a couple cardiologists on, but definitely the more the merrier as it comes to this data set, which again is very complex. Just quickly want to show some pretty interesting data from VHI. Again, this is an all-payer claims data set covering the entirety of Virginia, about 4 million patients. VCSQI has recently gotten a download of 2017 to 2018 for all PCI, open heart, and TAVR procedures across the state. So this is the initial look. There's about 24,000 patients in here, over 3.8, almost 4 million inpatient and outpatient claims, and then multiple different line items within each claim and episode. For a total allowed charge, they don't have a true cost or charge in here, but they have what's called an allowed charge, which is more or less their estimation of the payer charge, of about 36.5 billion for the 2 years in our population. So that's over 1.5 million per patient. I ran some quick calculations on the data set. Of those 24,000 patients, there's a good amount of overlap, actually. We had about 13,000 patients with a recorded inpatient PCI, 14,000 with an outpatient PCI, and then about 5,800 Cabbage patients. There's a total allowed charge, again, in the billions, with a capital B here for 2 of these 3 groups. For outpatient PCI, the charges were significantly lower. So instead of hundreds of thousands or even over 1 million for Cabbage, it was only in the tens of thousands for outpatient PCI. So I thought that was an interesting figure that we'll need to drill down into more deeply. But this is, again, just kind of meant as a high level look at some of our outpatient data here for the first time. And then I wanted to give one example, just one case study that I more or less randomly picked out here. This was a patient who near the start of 2017, was hospitalized, had a cath lab visit. A couple weeks later, came back for triple bypass. Seemingly was quiet for a number of months afterwards. You'll see little blips in the radar down here that barely register compared to the cost of the cath lab visit and Cabbage. These are our medications. Maybe a bigger one here could be a smaller office visit or something like that. Then in December 2017, the patient returned, though, was hospitalized for a wound infection and had a sternal debridement, which was almost $20,000 in charge. And about 6 months later, came back as an emergent case, was intubated for some time, and then had a cath lab visit as well, which was actually more costly than their original Cabbage procedure. So that's over a year later, but you see the costs, global charges were almost 4x that of the initial Cabbage procedure here. And this is just meant as a teaser here. Go ahead, Dr. Shor.
Yeah, so it just is kind of interesting to me. There's got to be a lot more information that we're not seeing. If you had a complicated patient who had a cath bypass and within a year decompensated, intubated, and taken back to the cath lab, and yet that total 2-year charges $200,000, $210,000, and that you were saying on average it's more than $1 million per person. So there's stuff that's included that we're not seeing that may be extraneous to the cardiovascular event, or we'll need to look at that a lot more, because
correct,
on first blush, this looks like a complicated patient and it's not anywhere near the $1 million mark.
Correct. And any and all charges are included in this data set. So, if they were in a car accident or had some other non-cardiac event, it's all kind of grouped in here together. And so it's up to us to kind of pick out the details that are meaningful versus, what's not relevant to us.
It might be interesting to see what percentage of the cardiovascular care is the total cost in this population.
We can do a quick calculation here, just based on these three figures. It's about maybe 15 billion divided by 36. So less than half is at least attributed to the cardiac procedures themselves. So there'll be more to come here, and this could be a potential avenue for some machine learning analysis as well, Gyula. A lot of data in here.
You just read my mind. All right.
So what's next as we hopefully flatten the curve here? We'll have our June 4th meeting on the calendar. We're hopeful that'll take place, but if not, we have a forum here digitally to hopefully accomplish some of those goals. We want to look at radial access best practices. We had a protocol from the Washington State Cardiovascular Society, COPE, who shared some of their best practice information with us. And we'll look to calculate some 90th percentile benchmarks as well with their group, as well as some others. And please be on the lookout for our full list of objectives and the post-op meeting surveys, as well as scheduling monthly visits with Sherri and myself. And just please consider us a community resource as we all navigate this tricky time. And any other comments, questions that anyone would like to share?
Eddie, this is Diana Alejo. I had a question about the third. I think if you could go back to the graph that you show cost by the three groups, one more. Yeah. So in the CAB group, where it's $8.4 billion, does that cohort include patients who had a PCI within that Cabbage admission?
Yes, correct. That can include multiple procedures within an admission. They're also not mutually exclusive. So there's some overlap for patients who had a Cabbage and a PCI, for instance, too.
Okay. Thank you.
You're welcome.
So Eddie, I guess we're wrapping up. We're past time, but thank you for all that were able to stick with us. Thanks to Susan and Rawn for their presentations, which were spectacular. To Gyula for all the work, for everybody for participating, and of course to Eddie and Sherri for all the work that they do with VCSQI. I guess if there's nothing else, we will adjourn and hopefully be in person next time. But if not, we've got an action-packed list of topics to present next time. Eddie, any last comments? Alan? If not, thank you very much.
Thank you, Dr. Shor.
Good night.
Good night.
Good night, everyone.
Thank
Thanks
you.
again.
Bye.